podcasting from a remote location that is nowhere near the heart of New York City. This is Crypto Characters, and I'm your host, Jason Nagy. We're very lucky today to have two amazing guests on this program. They're superstars. They're doctors that are risking their lives every day to help all of us in the community. Dr. Shreni Zinzuwadi and Dr. Safiyya Quintiliani. Dr. Zinzuwadia, Dr. Quintiliani, welcome to the show. Thank you both for coming.
Hello, thank you for having us.
Yes, thanks, Jason. Thank you very much for having us.
All right, so let's have a brief background on what your practices are so that everybody can know the perspective that you bring to this podcast and they can understand the perspective that you have for COVID-19. Shreni, let's hear from you first.
Okay, sure. So Shreni Zinzuwadi, I'm an emergency medicine board certified physician. I work in the emergency department. I've been doing this for 14 years, so I see all the patients that come in through the front door. We call the ER the front door because 90% of the patients in the hospital get into the hospital from the emergency department. So we see them, we assess them, we do an initial diagnosis, we do initial interventions, and we figure out whether they're safe enough to go home or need to be admitted to a hospital floor bed or are critical and need to go to an ICU. And then if they do have to go to an ICU, I pass them off to Safiyya Quintiliani. She's one of the pulmonary ICU critical care fellows, and she would take over their care if they needed such acute care as a critical care unit offers.
Dr. Quintiliani, let's hear from you now.
So Safiyya Quintiliani, I'm originally from England. I went to medical school in Cape Town, and I did my internal medicine residency here, and now I am a pulmonary critical care fellow. That is somebody who is in training to be a pulmonary critical care specialist, and pulmonary is all to do with lungs, and critical care is critical care, ICU care. It's two specialties in one, and it's about 3 years of training for that.
So let's talk about what you're currently seeing with the state of COVID-19 and the patients that are coming into the hospitals. Shreni, since you're the ER doctor, let's start with you, and then Safiyya, we could hear how you take it from there.
Okay, so I guess 2 weeks ago, we pretty much everybody we saw, we were admitting to the hospital. So the hospital was becoming very, very full. Multiple wards, floors were being turned into COVID units for patients who, were vented, non-vented, stable, needing oxygen. Anybody who needed oxygen would have to be admitted. So the hospital was ramping up the number of units. So right now that we've ramped up completely, we're holding steady. I'd say that we're holding steady. So the ER is still busy, but it's not as busy as it was. There's still lots of shifts where, there'll be 6 intubations in 8 hours. That's still happening where we are. But I think we're all very prepared now. We all have equipment. We're all kind of used to the pace and tempo of COVID sick patients that need oxygen or need to be put on a ventilator. So I feel like we went this high up, we went way high up, and now we're staying at this high level where we're all now used to being, and it hasn't gotten any worse. So that's why it feels like we're holding steady. I don't know, Safiyya can comment on the ICU situation, how she sees it.
Yeah, from an ICU perspective, we went from having one ICU where on an average shift you would have maybe 22 to 24 patients that you were looking after, to now having 3 separate ICUs. And what was our responsibility with just 24 patients before, at the height of it, I think we were looking after I want to say 50 plus patients. So it really did ramp up. We had to end up, breaking off into 2 teams because it was too much for one physician to look after. And now we have 3 ICUs. We haven't had to create any more in the last couple of weeks. So that's a good thing. And it's still very, very busy, but it definitely feels like it's sort of plateaued.
Here's a question. You just mentioned having to create ICUs. That strikes me as a somewhat unique experience that's fairly uncommon. Is that correct?
Yep. I don't think we've never done that before. So,
Shreni, have you ever heard of that in the 14 years that you've been practicing?
No. This whole thing has been unbelievably new. I mean, we've had so many patients come in that on the days that I'm not working in the ER, I've been helping with admission orders on admitted patients because there's still that many people coming in. that need care, that need doctors to write orders for them. And so in that sense, we don't have enough people. We're all chipping in to help. So the same thing with the ICUs, that, you know, classically it was like one ICU bed with 20 beds in it. Now we have, I think we're still holding at 80 ICU patients, right, Safiyya?
Yeah, so in the one ICU, we have 24 beds. They're all full. And then the newly created ICU, which was an observation unit before, can hold about, I think, 18 to 20 beds. And then the other ICU that they created also can take about maybe like 15 to 16 beds. So, yeah.
So now we're hearing a lot about intubations in the news. People talk about it, and it sounds like it's a fairly invasive process. Could you talk a little bit about what an intubation actually is?
Sure. So I'll talk about how we do it in the ER, and then Safiyya can comment how they do it in the ICU. But in the ER, we usually do rapid sequence intubation. It means we have a patient in front of us who, for some reason, isn't getting enough oxygen, isn't ventilating, their respiratory rate's too fast, they're not protecting their airway. We have a list of criteria of why we need to put them on a ventilator. When we do that, we do something called, we sedate them, or that's the induction phase, where we make them comfortable, make them relax, put them in sort of a medical coma, and then we paralyze them. Once we paralyze them, we use a chemical paralytic to ease the procedure. So once we do that, the procedure is getting a laryngoscope. It's a blade. You insert it into the mouth. It has a light on it to look down into the vocal cords, find the trachea, and you insert the tube into the trachea, attach the tube to a ventilator, and Safiyya will talk about settings and whatnot. And then we keep them sedated, because being awake with a tube in your throat is very, very uncomfortable. You have a gag reflex. It's a foreign body. It's not natural. Your natural breathing mechanism would want to vomit that tube right out or cough the tube out. So it's an uncomfortable thing to be awake for. So anybody who's ventilated or on a ventilator is in a chemical medical coma, sedated and comfortable after the fact. I don't know, is that how you guys do it in the ICU?
Yeah, exactly the same thing. Yeah.
So when you say that someone's on a ventilator, whenever they're on a ventilator, they're actually in a medically induced coma?
For the most part. I mean, some people they can be a little bit awake, and if they're not uncomfortable, then we'll just keep them lightly sedated. But for the most part, we make them as comfortable as possible. Some patients who are have been on ventilators for a long time, you change their intubation from being through the mouth to a tube that goes here through the neck. And those patients, it's less uncomfortable because, they can close their mouth and they can sit up, and they don't have to be chemically, in a medical coma, because it's not as uncomfortable. So it depends. Some people have been on vents for a long time or not, but then generally, if you've recently been intubated, then you will be.
So has the thoughts on the way the medical community is and the emergency community is treating patients that are coming in with COVID-19 and the use of ventilators, has that changed from the time that this became a notable pandemic in the US until now?
So the early literature that we were getting out of Italy and China always opted for early intubation. So if you saw that somebody was on nasal cannula, which is just the oxygen that you put through your nose, if you saw that level going up, then the thinking at that point was they're definitely going to end up being intubated, because their oxygen requirements would go up so rapidly. And I mean, we've both seen it. Somebody comes in, you put them on some nasal cannula oxygen, they look kind of comfortable, they look okay, and then within 6 hours, suddenly their oxygen levels drop. So the thought process was, that you don't want to do crash intubations, which is when somebody is, their oxygen levels are so low that, their heart may stop or something like that. Also, I think part of the thought process was that you wouldn't be exposing the medical care workers by, rushing in and doing things in that sort of situation. So it would be a little bit more of a controlled setting, and then you would intubate them early and, just leave them on the vent and see how they do. But as time has gone by, the thought process has changed a little bit, that maybe delaying intubation may be better. by just seeing how they do on, certain levels of oxygen, being a little bit more comfortable with them having lower oxygen levels. Like before, if somebody was below 90, I mean, for us pulmonologists, we're kind of okay with 88 of your saturations, but lower than that, you would feel very, very nervous, and, you'd want them to be intubated. But nowadays we're a little bit more comfortable. If somebody's sitting on the floor and their oxygen levels are like 86, but they look comfortable and they're not confused, then we may actually just watch them and see how they do and not rush to intubate them.
Right. So like from the ER perspective, usually if somebody, Safiyya was saying that pulmonologists are comfortable with 88%. So, 90 and above is what we like to see. It's normal. It makes us feel people are getting enough oxygen. So if it's below that, we kind of want to fix it. So we either put them on supplemental oxygen by nasal cannula, or the non-rebreather, or a BiPAP, which is a mask that goes across their face and pushes oxygen in forcefully, or they go on a ventilator. And what we were doing with the COVID patients, I think, was because their pulse ox emitters that measure their oxygen levels were so low, we would rapidly want to fix that, because that's what we do. We fix that, make it better. And so a lot of people were getting intubated very early. And I think now you're saying that we're finding that letting them have some hypoxemia, some lower oxygen levels, but they're mentating, they're awake, they're not tachypnic, they look comfortable, even though their oxygen levels are lower, you can just watch them, right? Is that what you're saying?
Yeah, that's what we've been doing on the floors. I think at some point, I'm not sure, I can't say for sure, but I think when ventilators started running out and we weren't rushing to, not us necessarily, but in other places, they weren't rushing to intubate, they actually started to realize that people with lower oxygen levels were doing okay. As long as they were awake and talking and fine, they were doing okay. And then also, while people are awake, we were getting them to prone, which, has something that's been in the news as well, where you basically get patients to go from lying on their back to lying on their stomachs. And that kind of opens up your lungs and your oxygen levels go up. And if patients were doing that and their oxygen levels were going up to 90 and above, then you didn't really see the reason for them to have to be put on a ventilator. And people were doing okay with that. Obviously, if your levels got a whole lot lower and you were confused, then the only other option really was to intubate you. But normally our natural instincts before this whole COVID era is, if you're breathing fast and your oxygen levels are even a little bit low and your chest x-ray looks bad, we would all say like, okay, intubation, and that's how we've always really practiced.
So you said that ventilators were running out, not where you were, but in other places. When did that start to happen? Because I've heard from press reports from governors primarily that they have enough ventilators, and there wasn't initially people were afraid there wouldn't be enough ventilators, that there wouldn't be enough PEP, which is personal protection, right? Personal protection wear.
Equipment, yeah.
Right. PPE, sorry, personally protective equipment. But then it seemed like everybody said we have enough. Is that in fact correct? Is there enough PPE and ventilators? Is there a shortage? What are you saying?
So with the ventilators for us, what we did run out of some traditional ventilators, but we were turning kind of BiPAP machines into ventilators. So we were still able to ventilate patients. But we never got to the point where we had to say, okay, you get a ventilator and you don't get a ventilator. At one point, the ethics committee was trying to work on a sort of strategy, if it gets to that point, where we would have to use certain criteria to decide, who would get one and who wouldn't. But we never really reached that level. We definitely had some really old ventilators coming out of the woodworks and, like having to use different modes and things like that. But we were never at the point where we had to decide, who got a vent and who didn't, thank goodness.
Yeah. What's a BiPAP machine?
So a BiPAP machine is something, some people wear it if they have obstructive sleep apnea. It's a mask that just forces air into your mouth. And it has 2 different levels. And it's the one that Dr. Zinzuwadi was talking about, that you can use before intubation, but you're also able to switch it into a certain mode that you can still use as a ventilator.
And Shreni, would like to hear what you had to say about that.
I was going to say, yeah, I think the projections across the country were, they were doing all those mathematical models for how many people were going to be sick. And I think that's when the fear set in about running out of ventilators. So I think everybody was very cautious and nervous about it. But yeah, I think we've all been doing okay with ventilators.
And how about the PPE? Do the doctors have what they need and medical workers?
We have what we need, but we are using it in a unique way. These masks and gowns were supposed to be one single use only. You go into a patient's room once, you put on the mask while you're in the patient room, and you dump it in the garbage. And now since every single patient we have has COVID, so every healthcare worker that's interacting with every single patient now has to wear PPE every shift, multiple patients, multiple shifts, multiple weeks. You're gonna run out if you use it as a single use only, right? If you do single use and throw it after every patient encounter, you're definitely gonna run out. So, we all, everywhere I work, we started one mask per shift and put a surgical mask over the N95. And now we are getting to the point where we're gonna have to clean the masks and reuse them. So we all have enough PPE, but there's just not enough, I think, in the world for the level of need that we're seeing right now. What do you think, Safiyya?
I haven't had to do any procedures where I don't have, proper protection or anything like that. We have face shields, we have gloves. Like you're saying, we're using it differently to how we used to before, but we haven't had a situation where I haven't felt like I've had enough to protect myself.
So did I hear you say that you wear an N95 mask and you put a surgical mask over it? Is that what doctors are doing?
Yeah, that's pretty much everybody's doing.
Why is that? Because I see people wearing one or the other. I normally don't see both.
I guess we're trying to keep the outside of the N95 mask clean, so we put the surgical mask over the N95. The N95 keeps out all the particles, keeps out all the small, teeny particles from coming into your respiratory area. But we all just, out of habit, put the surgical mask on over it to keep it clean. The surgical mask by itself doesn't work, but you can reuse the N95. The N95 is what you're reusing all the time. So you at least keep the surgical mask over the outside of it, theoretically, to keep it clean.
And if I go into a room and I've done a procedure or I've been in the room for a prolonged period of time, then I'll take the surgical mask off and I'll put a clean one on over that one. Because, you're like touching your face and you're touching your eyes and stuff like that. So at least you're keeping the mask underneath clean, and then you throw away the surgical mask if you had like larger particles on it for whatever reason.
Yeah, now, that one's more dispensable.
Got you. So is there, I guess, there's guidance now where I think in certain states you have to wear a mask if you go outside. Now, everyone says don't use the N95 masks, save those for the health professionals, and everyone's been doing that, right? But what I don't understand is,
except everybody in Whole Foods, I don't know where they're getting them from.
I guess there's a lot of doctors around. But turns out we had one kicking around our house. I think we got it. It came in like a painting kit that we had or something like that. And I didn't even notice it until I said, "Oh, what's this thing on here?" And it was weeks into this, and I said, "Oh, that's an N95 surgical mask." But I'll wear it because I'm not buying a new one, right? It's an old one. So what I want to understand is if there's all these let's just talk about surgical masks for a second, because I remember being told back when there was SARS and when there was the Middle Eastern respiratory system and SARS that don't wear these masks. They don't help unless you know how to wear them, and you shouldn't use them at all. And now all the states are coming out with laws requiring you to wear mask coverings, and if you don't have one, then they want you to use a shirt or they want you to use a bandana. Now, I've always listened to these people, so I don't really have a face mask that I can go around and use. So I use a bandana. But I feel like I've been lied to at some point, because I'm sure a lot of people feel this way. If we were told they don't work, they only work under special circumstances, and you don't know how to use them, so don't do it, and now we have to do it, what's the medical reasoning behind this? I understand why doctors have to do it and why they do all of this, but I kind of want to understand, is there any reason why, or is there any medical evidence to support the use of a face mask? And what are the different levels? N95, surgical, bandana, or shirt?
I was just reading an article on this today. I don't remember all of it, but the N95 keeps everything out, right? N95 is an excellent mask. I think it keeps out anything bigger than 0.3 microns in diameter, and your hair is like 70 to 100 microns in diameter. So it keeps out all the tiny particles. So it keeps out COVID. That's N95. So if you're interfacing with all these patients, you want N95. The surgical mask keeps out I think it keeps out like 20 to 30% of the particles that are bigger than 0.3 microns. But it's not, if you're really worried about it, that's not going to do it if you're interfacing with patients all day. The cloth masks will stop you from spewing respiratory particles on other people. Let's say you walk by somebody and you cough, or you talk, and when we talk, we spit a little bit, right? So if you're a little closer to somebody than you should be and you're talking, there's going to be spit coming out. So the cloth mask keeps your respiratory particles to yourself. I think that's the thought process. There's also a cloth mask out there where they have a little area with a filter that they're experimenting putting paper towels, 2 layers of paper towels, or a coffee filter in the middle. It keeps out like another 20 to 30% of the particles that are bigger than 0.3 microns. So I think all that's just to make people feel better when you're out in the street, that you're not going to cough your respiratory particles all over them when you're saying, hey, good morning, how are you? Spittle comes out, they're going to be like, hey, don't give me COVID, keep your COVID to yourself. And everybody feels safer around each other if they're kind of covered. I think it's for peace of mind and kind of general, keep your particles to yourself. That's what I think. What do you think, Safiyya?
Yeah, I mean, the talk about, if you don't know how to use an N95 mask properly, it's not doing anything. It's that we all have to, as healthcare professionals, have to do something called fit testing, where you have to go into this sort of box and they put all this like sweet stuff, and like you have to make sure that the mask fits absolutely perfectly on you for it to be any use at all. If you're wearing an N95 that's too big for you, you can still have, particles coming up here and there, and so it may not be as effective. So I think that's where if you're not wearing the right one, it may not do anything comes from. And I think that everybody wearing masks, while they were saying in the beginning, there's no point in wearing them, it's in terms of like protecting yourself from it. But in terms of like protecting other people from you giving it to other people, that's where it makes a difference. Like some in the hospital, some of our patients who we've had to put them on certain oxygenation machines that weren't recommended in the first part because they kind of aerosolized the particles and were more infectious. What we've been doing is putting surgical masks over those patients' faces, and that reduces the infectivity by them just wearing a surgical mask. Or even if you're, transporting somebody who has COVID, if you put a surgical mask on, that reduces it significantly because they're not spewing all these particles out. But it doesn't help you from you not getting it. So I think the mask thing was like, there was some truth to what they were saying in the beginning, but I think it was a little bit, construed. And I mean, I don't know if this was the case, but I think everybody also just didn't want to freak out the public by suddenly everybody walking around with masks, so they were saying, don't do it, don't do it. And now it's like, well, it could actually make a difference by not spreading it. I don't know. That's my understanding of it. I'm not sure.
Yeah. And to Safiyya's point, I think that's probably what they meant by you don't know how to use it, don't do it. Because, in the hospital, as she said, we have to get fit tested. So as she said, you put this hood on and they spray this saccharin. So if you smell it, the mask isn't working. And if you don't smell it, the mask is working. But we all get fit tested for our mask in the hospital. So if the public's just using them and they're using the wrong one and they were never fit tested, they're not doing any good if that's what they're trying to prevent. I think that's where that initially came from, as Safiyya said.
Well, that's actually the best clarification I've ever had, and I feel somewhat relieved that I wasn't completely lied to by whoever was espousing for the health community for the last decade. So thank you for that. That's huge right there. So now let's talk about ARDS. There's a video on YouTube of a doctor that's an ICU doctor, and he's in New York, and it's from the end of March. And he was saying that he was relating the treatment that's being used with ventilators as the wrong type of treatment, because from what he was seeing, and it was anecdotal, so it's not like we're going after him, but he was saying that anecdotally, he believed that this was, I think it was not an ARDS, which is, you can explain what that is, and that it was more like altitude sickness than anything else. So can you kind of talk about that video? I know that you watched it in advance, and just kind of let us know the state of how ICU doctors and pulmonologists are looking at how to treat COVID. Same thing with ER doctors as well,
Shreni. So it's interesting. I mean, I was really excited when I started reading all those articles about it. I'm by no means like an expert on it or ARDS or anything else like that. But I think what people were seeing was, the level of like hypoxemia, like how low your oxygen levels were, and how people were still able to, talk and be awake and things like that, which is something that we're not really used to. So they're thinking, there's something that's a little bit different about this, and in high altitude pulmonary edema, you do see that the difference in your oxygen levels of what you're reading on the outside to what your actual levels are. And then the other thing that they were looking at is, so basically in ARDS, one way to describe it is that you have almost like a thick sort of rubbery balloon that when you're trying to force air into it, it's difficult for this balloon to kind of blow up a little bit. So, it's very stiff and fibrotic, and your compliance levels are low, what we call compliance levels.
So Safiyya, you're saying your lung is this balloon that won't expand.
A lot of like multiple different units, like a sort of thickened, non-stretchy balloon. And what they were seeing in some of the COVID patients is that it seemed like there was more of like a thin balloon that was actually stretching very, it was stretching, and it wasn't
like
as ARDS.
It was stretching the way it was supposed to.
Yeah.
Some of them.
As opposed to having the thickened thing. So basically how you treat ARDS when you have these thickened lungs is that you, in a way, you have to give them a certain amount of support on the ventilator, what we call like high peeps, low tidal volume, so that you don't damage the lung, and that increases your oxygenation. But what they were seeing in some of the COVID patients is that they didn't have, is that they actually had very good compliance on their lungs, which meant that they were a whole lot more stretchy than they see in typical ARDS. So I was reading and like listening to these podcasts, and I got really excited because I was like, okay, this is something new. Let me try and do something different. And again, this is just anecdotally from what I saw last week when all of this stuff was coming out that I was reading. I went around and I tested the lung compliance of all of my patients on ventilators, and it was mixed. The majority of it still had very poor lung compliance, like a typical ARDS type picture, but some of them did have good lung compliance. And then I read an autopsy series that they did on some bodies in New Orleans, and when they looked at the lungs, the findings were still, for the most part, typical ARDS. And then Gattinoni, who is a anesthesiologist from Italy, who's like, one of the big ARDS guys, came out with an article a couple of days ago where he said that you have two types in COVID. You have like the non-ARDS type, and then you have the kind of ARDS type. I think those are the two terms. I have to correct myself there. There's type 1 and type 2, which is non-ARDS, and there's ARDS. So it's not homogeneous, basically, what's happening in the lungs. You're getting a mixture of two different things. And some of them respond well to the traditional ARDS treatment with like giving them high peeps on the ventilator, with proning, with all of those things. And there's some patients who don't respond to that. So I don't think that it's one thing or another. I think you have to look individually at your patient, knowing that they're not all ARDS, but some of them still seem to behave like typical ARDS. And that just means you're going to treat them slightly differently as well.
Okay, so it sounds like what you're saying is that, what does ARDS stand for?
What does it stand for?
Acute respiratory
syndrome.
Acute respiratory distress syndrome.
I know you were so used to saying ARDS, we always forget what our acronyms actually stand for.
And you see
acute
that
respiratory distress syndrome,
with like bad pneumonias or something like that,
you're having a hard time breathing. Is that what that means?
Well, they're on a vent and their lungs look terrible.
Yeah.
Does that sort of clarify it?
Okay, so
it's like the worst possible pneumonia or the worst possible pulmonary edema. The lungs are just filled with, I guess, what do you think, Safiyya? They're filled with fluid, and they're on a vent, and even though you put them on a vent, they're not doing well. They're not oxygenating well. So typically in ARDS, as Safiyya was saying, they do things with the settings like increase their PEEP and decrease their tidal volume, which is very pulmonary.
So like all your lungs are made up of these tiny little sacs called your alveoli, which are sort of like balloons, that are, as you breathe in, they kind of open and stretch. And as you breathe out, they collapse. And in ARDS, they get very thickened and stiff.
Okay. And so in other words, there are some people with COVID that will have ARDS and they need a souped up ventilator, or you need to adjust the settings. And then there's another kind that you can do all of that, but it doesn't help them, or is it the other way around?
Kind who may be doing the typical ARDS thing may damage their lungs a little, because you're giving them, it may cause damage to the lungs is what the thinking is now. So that's why you have to tailor your treatment according to your patient.
And I guess that would also mean that, is it easier for them to breathe, or that's just completely irrelevant? It's more about a treatment regimen than anything else.
Right. Yeah.
Okay.
And they'll respond to certain treatments that the other patients won't respond to, like proning, for example.
Gotcha. Now, before we go into mortality, which is the second to last thing I want to talk about, could you just explain what proning is? Because you've used it a couple of times and I don't know what it means.
Yeah, so proning is basically where you take a patient, whether they're ventilated or not, and then you just turn them from their back onto their belly. That's it. And then it just opens up your lungs, your oxygenation goes up. It's fairly, benign, but it really works really, really well. We're doing it on a lot of our wake patients that we, never really used to do in the same way before. And it's like really helping a lot of people from, ending up having to be intubated. Well, I mean, that's just anecdotally. I'm not sure like what the.
But in the patients that you've seen, when you've turned them prone, when you've put them on the stomach, has that actually, well, here's a question. When you do that, has that prevented what you thought would be an inevitable intubation, or has that just helped them breathe?
Yeah, because your oxygenation levels go up significantly. If your oxygen levels are really low, your chances of, having, some sort of damage, like becoming confused, not protecting your airway, maybe even if your levels go as low to like having, a cardiac arrest or something like that, where you have to, crank up their oxygen. If you prone them and their oxygen levels go up, everything gets a little bit better. Even for example, on the vent, if they're on 100% of oxygen and you prone them and you can go all the way down to 40% of oxygen, you are reducing the amount of, toxicity from the oxygen that you give them, which is a really good thing.
So you're either delaying the intubation or you're stopping it from happening altogether. You're buying them as much time as possible. And even all the patients that I sent home, from the hospital that I think have COVID, but they're not sick enough to come into the hospital, that I send home, I tell them to sleep on their stomachs, because when you're on your back, all the bottom of your lung is collapsed. But when you're on your stomach, theoretically, you're recruiting all the bottom of your lungs to open up and to help you get more oxygen. So that's sort of the way we're thinking about it.
Now, are there other things you could do? I think I recall someone who would run a lot would say that at the end of a run, you want to put your hands over your head like this and walk. Does that help with oxygenation, or is that just is that like a chicken soup for a cold kind of thing?
I don't know.
That would help. I mean, I guess think about it. I mean, I think
your lungs a little.
Yeah. I mean, you'd be exhausted staying like this all day. That's the problem. That's why it's easier to be prone, because you're going to get fatigued doing this all day.
I sleep like that all the time. So. All right. So let's move on from ARDS to mortality. What are you seeing in terms of the deaths, or the death rate, or the way that COVID treatment is helping this, preventing it, making it worse? What can you tell us about what you're seeing, when you're in the trenches and in the ER or in the ICU?
From an ICU perspective, we started after the first week of, when our COVID unit really sort of ramped up, we started doing steroids, which initially were not recommended for in the original like COVID literature. You know, they're not recommended for viral pneumonias, and there was also some thought that, you know, if you give steroids too early, they will enhance the viral replication. But it was the one thing that we noticed in the beginning that you know, with actually reducing your oxygen requirements on the vent. So it felt like it was working. We'll have to do studies and look back to see, you know, if there's been an overall mortality and morbidity benefit to that. But like anecdotally, that seemed to be doing something. Hydroxychloroquine, I don't know, from an ICU perspective, I think a lot of the treatments, you know, by the time they come to the ICU, it's the disease is kind of already full blown. So there's not much extra you can do except for, you know, support them and see how their body responds to it. We're enrolled in the remdesivir trial, and that seems to be having some like positive results. Tocilizumab, which is an anti-IL-6 medication, if that's given early on in the disease, it seems to have some sort of effect. We stopped giving azithromycin in the beginning because there came, you know, some studies came out that said azithromycin doesn't really do anything, so we don't do that anymore. And yeah, I mean,
I think to your point that the data is changing so fast. Again, I know everybody's saying this, we're going to say it too. We've never seen this before. Everybody's rapidly trying to figure out what's going on. The information changes all the time. You know, I talk to my colleagues too. It's like, first you shouldn't give steroids. Now you should give steroids. Plaquenil doesn't work. It does work, you know. High PEEP, low tidal volume, maybe not. Prone them. Like the data is just changing day by day, week by week. So for the medical community, it's frustrating and exciting, right? We're actually doing this in real time. There's not a lot of time for randomized control trials, although some of them are happening. And mostly it's just like being really smart and trying to figure out what's going to help your patients. And you're against the clock, right? So we're in a unique time, but the data is changing all the time.
Now, if you look at the charts, I was looking at the New York City charts for deaths, hospitality. There are dramatic differences in age brackets. 18 to 44 is, from a death perspective, it looks like it's minute. 45 to 64 is also pretty low. And then when you hit 65 to 74, it gets fairly high, and 75 plus, it shoots up a lot. It's like at the top of the graph. Are you seeing that reflected in the patients that you've been seeing over the last 3 weeks? Is there a really big difference between the way it affects ages? And I ask that because everyone is talking now about reopening the economy, and I think that everyone is for that, and then everyone's just trying to figure out how to do it. So from the perspective of staging, if you're using ages and you say, okay, if you're not obese and you don't have cancer or pulmonary disorder or a whole slew of things, then it's going to be okay for you to go to work first. If you're 65 or you're 75 and up, or you have certain health issues, when you combine it, you should stay home until we get a vaccine. What are you seeing, just so we can get a feel for how this affects these different age brackets? Are you seeing major differences in them? Safiyya, let's start with you.
So let me see. So in the ICU, we've been seeing a mixture of ages. Majority are older. We have had some younger people as well. I haven't had a truly healthy young person in the ICU yet. We've had some 40-year-olds, but they're like either diabetic, hypertensive. I've had some 20-year-olds, but they have just had children, and there's like a theory that maybe they had some sort of like, you know, cardiac involvement, which maybe made it, you know, a little bit more difficult for them to battle the virus. But for the most part, I think once you reach the ICU stage, your mortality goes up significantly regardless of your age. But we have been seeing obviously a lot more older people than younger people, and almost everybody has some kind of comorbidity. It's been interesting to see the types of comorbidities in the ICU as well. We have, our
Can you explain what comorbidity means?
So other health conditions.
Related to your death, correct?
So no. So for example, if you're a diabetic, that's a comorbidity, or you're a hypertensive or something like that. And I've been disproportionately seeing more diabetics and hypertensives than anything else. When this all started, I was thinking we were going to see a lot of HIV patients because we have a large HIV population. And I've seen one the whole time. And this is an infection, and you'd expect to see a lot more HIV patients, which is really interesting. But almost everybody is like diabetic, which is also very interesting to see observationally.
But it's not hitting kids at all. Like, this is not a disease that affects children. I mean, nobody under 12 is getting sick, and then maybe there's one or two outliers. And as you said, the teenage population, you don't really see it. There was like one sick pediatric case. And then the young adults, if they're healthy, you're not really seeing them.
Or they're getting it, but they're not maybe ending up in the hospital, or definitely not in the ICU so far.
And right. all of that, essentially, we're not testing right now for antibodies. So from what I've understood, that throws off the mortality rates that we're seeing. Is that in fact something that the medical community has accepted?
I mean, we're not just testing people in general for COVID, not the antibody test, right? You just mean like seeing if you're positive or not.
I mean for both, right? Yeah. In other words, if 50% of the population has had it, it changes. Yeah. Then you look at the deaths, it changes it. So I'm just curious, as practicing doctors on the front lines in New Jersey, I wanted to get your take on that, or the medical community's take, not your individual take, because, and I'll put this in there, this is not medical advice. You're just talking about what you're seeing. So.
Yeah. I think when the antibody test comes out, all healthcare workers are super excited to be tested. We all want to be tested. We want to know if we were immune. We want to know if we were, if we had it and we just weren't sick. So yeah, I think we should be the first ones tested. I don't think it's ready yet. The antibody test is not ready yet. I think they're talking about it in lots of different places. So maybe we're almost there. But we should be the first ones to be tested. And yeah, it will change the denominator. That's what you're getting at. I think it will.
Yeah, right. Even just all the patients that come to the emergency department that look like they definitely have COVID, who are not tested because they're not sick enough to be admitted to the hospital. That again is like a whole chunk of people that, we just don't know on file whether they have it or not.
Right.
Again, would make the numbers look a lot better.
Right. And even the test, I feel like I've been hearing that the test only has a sensitivity of 70%. So that's a 30% false negative rate. So.
Yeah, we've retested a couple of people that we're, 100% sure this is COVID, and it came back negative, and we've retested them again. And they come back positive.
Right.
So does the medical community have any best practices for not contracting COVID-19?
Stay at home.
Lock yourself in your room. No. I mean, you can't really live, right? I mean, if you have to go to the grocery store, wear a mask and gloves and wipe down your stuff, be kind of germy, be vigilant of the germs. I think we all have to do that now.
Mm-hmm.
And the reason why
if you go out and you have to go to the grocery store, you can't not do those things, right? You have to do them.
You have to live, and they're talking about opening up the economy, and all the governors in varying states are trying to figure out plans. And so what I'd like to know really is, okay, we all have to get back to work. The economy has to restart. People need to be able to pay for food, right? There are food bank lines all over the country. Food banks are running out of food. So we need to get people to work. And so what I wanted to know is, if you do this, the major metropolitan areas, there's population density. And what I think people are starving for right now is, when you go to the doctor, what is the doctor going to tell you about how to not contract this thing? So wear gloves. Now, does it have to be those plastic gloves, or could it be like the gardening gloves with the rubber bottoms that you see trained conductors wear, with the rubber grips? I mean, are leather gloves okay? Should you go out and try to get, so you need to get fitted for these N95 masks. Should you stay out of the trains unless you have a surgical mask at a minimum? I mean, are there any thoughts that the medical community has about this, just from practicing, just from a best practices perspective?
I mean, we're experiencing this in real time. There's no model to look after. So let's say when the curve is flattened and the economy opens up, I have the same question. When I go out to the grocery store, am I now going to not wear a mask? When I take my kid to soccer, am I going to stay away from people? Am I going to speak at a distance from them, or am I going to wear a mask and gloves? And if you wear the gloves that aren't disposable, you're going to have to wipe them down, right? That's the point of the disposable ones, is that you throw them in the garbage. But if you're keeping gloves that are reusable, you're going to have to give them a wipe down with Lysol or bleach, or rinse them in hot water and soap and clean them. Or you're going to get a UV light and you're going to do the 10-second wand of UV light over everything. I have a colleague who already bought his UV light, and he's a doctor. And when he brings his groceries home, he scans his groceries before they come in the house. So that's probably what people mean when they say life's never going to be the same again. Because when things quiet down, are we all going to let our guard down, or what are we going to do? I don't think we have an answer yet, but I think we're going to be more vigilant, and we're going to be a little bit weary of being close to people or not wearing a mask and being, very, very, in intimate parameters with people. So I think it's going to unfold, and I don't know if we know what to say yet. What do you think, Safiyya?
I mean, yeah, I totally agree with you. I don't really have anything extra to add to that.
Yeah. I mean, I think Governor Murphy said that, or phase 3, when the bars open back up, you can be at a bar, but you can't be in crowds of greater than 10 people. So are you going to be at a bar with your mask on and then pull your mask down to have a sip of your drink and then pull your mask back up? I was trying to imagine this. When you're at dinner, you're wearing a mask and you pull your mask down to eat, then pull your mask back up. I don't know how it's supposed to look.
It's going to be a bandana. It's going to be like Jesse James out there.
Yeah, I think we don't know yet. It's going to be strange. Things are going to be different from what they were before COVID, because we get a respite of the summer, and then the fall comes back again, and then the cold temperature is supposed to bring the second wave, and we don't know if we're going to be immune or not, or if it's going to be as devastating as it was the first time. It's a live experiment we're all in.
Imagine if you get like a passport which has like your antibody test on it. It's like, oh, okay, you're good.
Right.
You can come in.
And I mean, there's talk of temperature testing, which strikes me as trying to stop the horse after the barn doors close, or whatever that. Sorry, I didn't grow up on a farm. Closing the barn door after the horse is out, whatever that one is. But it sounds like
the horse is already out of the barn.
Yeah, thank you. There you go. So I mean, it just seems like it's somewhat ridiculous to be testing people for temperature, because the vast majority of the people that the vectors that could be infecting you, they're out there and you don't know it, and the temperature is not really a gauge.
No.
Right. I mean, some hospitals I work, they test your temperature before you come to your shift. So then they're going to send me home if my temperature's high. But I don't know. It's like it's a sort of desperate last minute move to try to protect people. It's coming from good intentions, because what else can we do?
Mm-hmm.
Right.
But you're right. You're not getting the silent carriers. You're not getting the asymptomatic people that are vectors. You're not.
All right. So let's end on a positive note. I had the wisdom to ask you at the last one we did, Shreni, if you had any final thoughts, and you had some great thoughts that left me uplifted, like at the end of Avengers Endgame. So, let's hear final thoughts.
I mean, I will say that I was feeling really, really sick this week. 3 days ago, I had body aches. My hamstrings and quads were killing me. My lower back, I was fatigued after planting. I had to take a nap. I swore to God that I had COVID. I got winded going up the steps. I just got tested. It's negative. Part of me thinks it's a false negative, but I am getting better. And I'm very eager for the antibody test. And I'm still pounding my immune system with supplements. I'm taking vitamin D, vitamin A, vitamin C, magnesium, zinc, and all kinds of other good stuff. Green leafy vegetables, lots of colored fruits and vegetables, and boosting my immune system. I 120% believe in that approach. That's my good for the day. What do you think, Safiyya? You're young and healthy. What do you think?
Positive thoughts. This is the one
No,
question I wish you'd asked me before, and I would have tried to prepare something.
It doesn't have to be positive. Just parting thoughts.
Parting thoughts.
Just can't be morbid.
Parting thoughts are, I think it's very interesting. I think that every couple of days something new comes out, a new thought process, comes. You have to be very open with regards to this, and not thinking that we have the answers, and just keep reading and keep listening to other people, because it's changing all the time. I think that we're definitely going to be doing this again soon. Yeah.
Well, how about this? As a pulmonary specialist, can we prepare our lungs in a way to make them healthier? In other words, is running or doing exercises that make you pant, or certain types of breathing exercises, is that helpful to your lungs the way that you can exercise a muscle, or does that not work for organs? Is there anything that people can do to prepare, aside from the supplements that Shreni mentioned, and getting a lot of rest, which is hard to do at times? I mean, are there things that you can do as an individual to prepare your body for, let's say, the fall? You've made it this far, the fall or the winter.
I mean, overall, being healthy and your body being strong is a thing that's going to help you more than anything with regards to getting any type of infection, especially something like this. Like I said, we haven't seen very many truly healthy people. So just, getting your chronic conditions under control, losing weight, being healthy. If you're like borderline diabetic, trying to stave that off. If you're, I always was, telling my husband about smoking, but that hasn't really come up as a big thing that has been a bad thing with people with this COVID infection. So, but still, it's a good idea to stop smoking. And just like overall health,
Yeah. Oh, I was gonna share something on that. Oh, exercise is anti-inflammatory. And look, none of this stuff is studied, right? I saw that J.K. Rowling put out a video of breathing exercises that helped her beat COVID. I haven't watched it yet, but this is not science. This is not something that's been studied, but it probably will make you feel better. People do CrossFit endurance training. They wear a gas mask when they're doing serious, training. So I'm sure that helps their lung compliance. That's why they do it. So there's stuff out there in that world that probably makes your lungs stronger that you can do. Or just, breathing exercises will help your outlook, will help your disposition, will decrease your stress level, which will help your immunity, right? And exercise.
So exercise, and by the way, I'll put a link to this, but Wim Hof has an amazing breathing. He's a breath specialist. And if you want to learn how to breathe, him or Laird Hamilton, those are the guys to go to. They're super, super great with breath.
Yeah, definitely include that. I would watch it.
All right, so we'll do that. Shreni, Safiyya, Dr. Zinzuwadi, Dr. Quintiliani, thank you very much for coming. Thank you for being on this podcast. Appreciate your time.
You're welcome.